class of drugs known as bronchodilators, and it works in the airways by opening the passages and relaxing the muscles. If you look at lines 64 through 74, it requires boards of education to adopt a policy authorizing school personnel to administer albuterol sulfate if it's available to a student in distress, whether or not the child has a prescription. Each Board of Education shall provide information to its employees on how to recognize respiratory distress and the correct method of administering albuterol. And school personnel who administer or choose not to administer, they have a choice, shall be immune from civil liability. In conclusion, 79 through 85 state that a licensed practitioner can prescribe albuterol sulfate to the schools, and a pharmacist may dispense it to the schools. This is very close to Josh Clark's bill on EpiPens, and also it permits a supply to the schools, training to school personnel to act in an emergency, and again, it's encouraged by our Asthma Coalition and our Center for Disease Control. And we have a special guest today in Dr. Redding. Thank you so much for being here.
And for the committee, Dr. Redding, weren't you fresh out of residency and starting practice when you brought us the EpiPen bill? They're just
Yes, I was a couple years out of training. That was about 4 years ago.
And all of a sudden, an email came across my desk, and somebody was very worried about what was happening to the children in Georgia and what we needed to do, and worked that bill until it passed the both houses and went to the governor for a signature. So thank you for your involvement and for being concerned about Georgia children. So what would you like to add to this, and then we'll let the committee ask questions.
Well, I think this is an excellent bill because if you put yourself in the school nurse's shoes and you have a child in front of you or teenager who you're very confident that the person's having an asthma attack, and it may be the first week of school and the student does not have a prescription on file at the school that says John Smith can receive albuterol, it would be a very frightening feeling to think, well, I'm not allowed to give this person a very safe medicine which could help him just because there's no prescription on file at the school. The crux of the matter is the albuterol is such a safe medicine that there's no adverse effect of giving it, and in the minute chance the person's symptoms are not due to asthma, let's say they're due to pneumonia, which is pretty rare to have serious pneumonia develop at school, but it is not going to hurt the student to get a couple of puffs of albuterol even if it's not asthma. So there's really no downside to the law, and there's a great upside to the law, because it can certainly buy time if the person's having a severe asthma attack for the ambulance to show up and be transferred to the hospital. So it's an excellent bill. There's really no negatives to it.
So basically, it's like the EpiPens, because there was some concern about giving the EpiPen, and I think what you told us that time is that often you have to give more than one dose of the medicine in the EpiPen to stop a reaction, and there's no side effects to it, so there's really no side effects to this one.
Right. Basically. There's really no side effects to albuterol if given in the form that is given in the recommended dosage. So it's totally safe.
Okay, thank you. Representative Kelly.
Thank you, Madam Chair. I guess this is a question to Representative Clark. Is this something that in 64 through 70, the requirements for the school boards, is that something that they will have to do whether or not they choose to carry the albuterol? Because, I mean, we said at the beginning that they may, they have the option of whether they want to have this prescribed to their school or not. But then we're saying they shall have training. Does the training only follow if they're going to have the prescription at the school?
Mr. Kelly, that is such an excellent question, young man.
All my questions are usually pretty good, I think.
This one is a better one.
Oh, don't let that head get too big, young man.
Actually, yes, they do. Everyone does receive training, and that would allow a teacher in effect of a dire emergency to take a nebulizer. Well, there wouldn't be a nebulizer, but an inhaler, and he's such a good demonstrator, and be able to use that inhaler with the child. If the teacher was trained, that teacher could use an inhaler with another child.
So if my local school system didn't want to have these prescribed to school, would they still have to do training for all their
Yes, sir,
employees?
they would. Yes, that's correct. And it happens at the beginning of school. You talk about peanut allergies, you talk about EpiPens, and this would be included when the school nurse comes and does a demonstration and talks to teachers in every school, as they do at the beginning of school, about certain allergies and things that would help children throughout the year.
Okay.
Okay. That would be, so Representative Kelly, you have one child that has the inhaler, you get a child in distress, and rather than let a child die, like with the EpiPens, you take that one from the other child and use it on the other one, so they would be trained to do that in an emergency situation like that. I mean, we're talking about life-threatening children. As you said, 10 children die from asthma attacks. I wonder how many others are hospitalized from school from the asthma attacks when they're real severe. So, okay. Representative Hawkins.
This is for the doc. Now, I know the albuterol is mainly affecting, its action is actually on the beta-2 receptors in the bronchioles, but in adults, we have to also think about those receptors also being in cardiac muscle. So I know if I have a hypertensive patient, then that's a consideration for me to be giving this drug in my dental office. I hear that you're saying that's not the case in adolescents. So my question to you is, what if you got a high school kid, 17, 18 years old? Could this be a problem if that child or pre-adult is hypertensive?
Yeah, with albuterol or levoalbuterol, they are so selective for the receptors in the bronchial airways in the lungs, and they're so poorly selective for the beta receptors in the heart that you're not going to get enough activation of heart rate to cause any problems, even if the teenager has hypertension, because they're just so selective, as opposed to the ones that were more popular in the 70s and 80s, like isoproterenol and some of the others that did have more of an effect on the heart. So because this does have such a negligible effect on the heart, it's perfectly safe, even if the person does have a heart condition, and if they're having respiratory distress or asthma attack, you can give 2 puffs. It's not going to have enough effect to cause any problems.
So there's no
basically.
warning on that, on this drug, for hypertensive patients?
There's a warning for people on drugs which really aren't even used in the under 18 population, like digoxin and monoamine oxidase inhibitors, which nobody uses. Just for hypertension itself, I don't think there's a warning just for hypertension. Okay. But what would stress the heart the most would be the asthma, would be the trouble breathing and the asthma attack. That's what would cause stress on the heart, not the albuterol.
Okay, thank you.
And Representative Hawkins, we promise when you go back to repeat high school, we'll send a note with you and we won't let anybody give it to you. How's that? So anyway, Representative Broadwick.
Thank you, Madam Chair. Throughout the bill, you reference levoalbuterol rather than albuterol. And I think to clarify, because we've got 2 different products there, levoalbuterol being a more selective product. And so I think for terminology, they therapeutically would be interchangeable, but for terminology, we need to list both products. The levoalbuterol is going to be a much more expensive product for the school system than the albuterol product. So we need to clarify that so that it's either or.
Right, that's exactly right. Yeah, we're working on that.
Okay.
We intend to do that.
MSI.
This morning we had a conversation, and it pertained to levoalbuterol, and so we do need to have both included in this. And so if Madam Chair would allow us to amend it to include both.
So Representative Broadwick, are you saying that since that's a technical thing, that Betsy could insert the word "or" between them wherever they mention, and that would take care of it?
Either or, yes.
Either
I mean,
or.
Therapeutically, they're the same, but if you specify the levoalbuterol, you're talking about a product that would be much more expensive for the school system.
Betsy, can you handle that in every place that it needs to be put in?
Well, I think if we would just put it on line 21, it says it would say single dose of
Correct.
We would use the same term throughout, but it would encompass both.
Right.
Okay. All right. I would take that as a friendly amendment, and no one has any objections to it. Okay, technical amendment. Okay. Representative Jaspers.
Thank you, Madam Chair. Representative Clark, this one's notification of a parent when this has been applied. Is that something you're leaving to the school board, or is this? I kind of scanned through it. I didn't see that.
I would assume that that would be in the school board policy.
Okay.
That could be there. If you would like it listed, now that we're doing amendments, this is the time.
Oh, I don't know if it's necessary or not, but I just
Okay.
wanted to,
I
I know
would
that's
assume-
something you always
I would
are
assume
thinking
that
of.
would be part of board policy, but if you are more comfortable, we can list that.
I'm fine with that.
You're fine with it like it is?
Yeah, I'm fine with it.
Thank you,
Just
Mr.
wanna make sure.
Jaspers.
Representative Harden.
Thank you, Madam Chair. I did have a question before the meeting on the disposition. Of course, these inhalers will have had someone's mouth on them, but they can't be sent home with a student because a student may have a different prescription at home, and that would not be the thing to do. But I checked with Betsy, and she believes that's involved with the other, the methods of disposition of the product after use is addressed, I believe, in other law. Is that right? Okay.
All right, thank you.
Thank you, Representative Harden.
Okay. Are there any other questions for the author of the bill or Dr. Redding? If not, at this point, I'm ready to entertain a motion from the committee. Okay, I have a motion to accept the bill and a second. Any further discussion? Is there anyone in the audience that wants to speak to this? Do we have anybody? We don't have anybody signed up. You come in? Okay. No one in the audience. So everyone in favor of the passage of the substitute to House Bill 362 as amended, say aye. Aye. Anyone opposed, no. The ayes have it. Dr. Redding, thank you very much for coming again. It's nice to see you, sir. And Representative Clark, you ready? We'll just let you go ahead and do 436, House Bill 436. You can say. We'll be glad to have you stay and talk about HIV or syphilis.
I'd like to stay and talk about HIV.
So anyway. Okay.
Madam, another cheer up. This will be sexually transmitted diseases now.
Okay. Go ahead, Valerie.
All right. Thank you, ladies and gentlemen. Madam Chair, I bring for your consideration House Bill 436. And this is a bill that requires physicians to have a conversation with pregnant women and offer testing in HIV. This also would offer the new part of this bill requires that physicians do this in the third trimester and also add syphilis. Also, at the time of delivery, if there's no written evidence that the HIV test or the syphilis test have been completed, once again, the physician will order a test for HIV and syphilis. And again, the woman can turn this down, and also the physician does not have to have this if the woman has been tested before, and if the physician feels as if there's no reason to conduct another test. One of the reasons for this bill is that if you are HIV positive and you are pregnant, when you deliver this child, there's a very large chance that the child will be HIV positive also. And if you diagnose before or during pregnancy, appropriate steps can be taken and the risk to the mother and the child are lowered to 2%. And to me, that's an incredible amount. So mostly you get this, you would contract HIV in the birth canal and from breastfeeding. Also, syphilis, if a child is born with syphilis, it could be also have including brain issues, issues with the eyes, ears, several organs can be involved, and a prenatal visit, repeating this in the 3rd trimester, would allow the pregnant woman to be treated. And if she is treated for syphilis with antibiotics that are very safe during pregnancy, that child can be born without syphilis. So these are very important activities for a physician to conduct testing, and also to offer testing for women in this 3rd trimester and before the baby is born.
Questions for Representative Clark? Go ahead.
They already have the conversation with women. The pregnant woman can turn down the testing, and testing is offered during the 3rd trimester and again before the birth of the child.
Okay. Representative Drenner.
Thank you, Mr. Chairman. I'm curious. You're just testing the mother. You're not testing the baby.
At this time, you're offering the test for HIV.
To the baby.
It would be to the mother.
To the mother.
Yes,
but
ma'am.
so you're not. Are there?
It's prenatal.
It's prenatal, Representative Drenner, before they're born.
Can you convert during pregnancy? Can the baby convert and the mother be negative, or do you know what I'm trying to say? Is
At birth?
Yeah. So can the mother be positive and the baby could be the mother was positive treated? Could the baby still be positive and untreated?
Yes, it goes down to something like, okay, if the mother's treated, right? Mother's positive and she's treated. The earlier you get into the pregnancy, it goes down to where it's only about 2% that are born HIV positive. So the sooner you can start treatment, the better. But women are slipping through the cracks. We're not catching everybody.
I just don't understand why you don't test the baby too.
It's prenatal. It's 3rd trimester.
Right, but at the end when the baby's born, if the mother already tested positive, why wouldn't you test the baby?
Well, you probably would, Representative Drenner. You
Do we have
most
somebody
likely
from
would.
public health here? We know when they're born. Okay, David, can you speak to that? Come up and identify yourself. They obviously know, Representative Drenner. I think the answer is going to be they do test them because they obviously know if they're HIV positive. We have a number they're born. Okay.
She has to test the newborn if the mother is HIV positive.
That's up to the physician. We don't have a statute in place that requires that. But my assumption is that most physicians, if you know that the woman was positive, you would test the baby as well. But there's no law in the books that requires that.
Okay, thank you.
But I believe that would fall under a standard of practice. If you knew the mother was HIV positive, I think the standard of practice. Now, I may be wrong. Is there anybody here from the OB Society? But okay. Laura?
Excuse me, because can I speak from here?
You can.
Okay, and I'm Laura Susi. I'm a pediatric nurse practitioner. Currently, my practice site is with Marion in neonatology as well. So our practice is if we have an HIV positive mother, the baby is automatically tested, and we don't discharge any. And what I'm not understanding, I don't know if it's just a hospital policy. We don't discharge anyone from the hospital unless the HIV status of the mother is known.
Well, that's not the way it happens everywhere.
Yeah, but that's our practice there.
Good for Wellstar. Way to go.
This once again.
Any other hospital representative want to come in about their hospital? Deb? No. So,
To
do
be
we?
honest with you, Madam Chair, I'm not sure what we're doing on that.
So, the other thing is okay, is it my understanding that the other thing this would do is if you get an HIV positive mother, then you put everyone in the delivery room at risk of being exposed to HIV. So implores us to try to catch the HIV positive mothers before delivery so we can protect not only the baby, but we can protect our hospital staff. So,
And again, the mother can turn down testing at every point.
Representative Henson. Okay, it's passed. Representative Parsons.
Thank you, Chairman. Yes, ma'am. It seemed like a really good bill to me. I wanted to ask you that. It was my understanding when you were presenting the bill, I may have misunderstood and probably did. You had said the mother can turn this down at any point, but I thought I understood you say that the doctor, and it says that, let's see, I believe it says they shall have to do this, but I thought I understood you say that they could, a doctor, if he saw no evidence or whatever that it needed to be, the test needed to be done, that it was, that he could make that decision. Did I misunderstand you on that?
I'm sorry, could you repeat?
Okay, I'm
the
sorry.
doctor has to make the decision?
Yeah, I thought I understood you to say when you were presenting the bill that in addition to the mother being able to turn this down at any point, that the doctor would be required to do it except if he saw or felt like there was no need for it. I mean, did I understand you to say that?
Look on lines 27 through 31. If she's already had testing and she does not appear to be at risk, then it does not have to be a question again at the time of delivery. But again, at the point of delivery, the physician can order the test, but once again, the pregnant woman can turn this down.
Okay, thank you.
I mean, if you'll remember, Representative Parsons, a few years ago, we passed a bill. We were getting something like maybe 40 or more babies every year born with HIV, positive for HIV, and they cost us hundreds of thousands of dollars because most of them are on Medicaid. Not to say what all that does to their life and being treated throughout their life for this. And it was where pregnant mothers at that time had to opt in. And what we did is always said they had to opt out. And so by doing that, we greatly reduced the number. But what we're finding now is that some people are becoming infected. You know, when the physician sees them in the first trimester, they're becoming infected between the first trimester and the third trimester. And that's the reasons for going back with this again.
And the benefit to the newborn is overwhelming. To have that go from full-blown HIV to down to 2% is just such a benefit.
Representative Pizzo.
Thank you, Madam Chair. What is stopping a doctor from currently offering this test?
They do offer it in the first trimester. They always do offer it. It has been history that they have offered it, and this now again is as Madam Chair said, for those women who slip through the cracks and become infected between the first trimester and the third.
But they can still offer it at any time.
Yes, sir, that is correct.
Okay, thank you.
Thank you.
Representative Jones.
Thank you, Madam Chair. I think this is a good bill, but my question has to do with the unborn baby. What happens if the mother refuses the test, but the baby is born with HIV?
And that's a possibility. Representative Jones, that's a disappointing possibility.
Let's ask the person who asks really good questions that are always perfect. Representative Kelly, do we have anything in the law books that would indicate that that's a misdemeanor or a felony?
I don't like surprises either, Madam Chair.
Especially when it's your baby.
I don't believe that we have a statute on the book that has any kind of consequences for what would happen. We can look that up for you, but I'm not sure that we have anything on the statute.
And Representative Jones, that's an excellent question.
It is.
Thank you.
Any other further questions? Is there anyone in the audience that would like to comment? Okay. All right. I'm ready to entertain a motion. House Bill 436. Got a motion do pass. Do I hear a second? I have a second. Any further discussion from members of the committee? Hearing no further discussion, everyone in favor of the passage of House Bill 436, say aye. Aye. Anyone opposed, say no. No. Okay, thank you, Representative Clark. The ayes have it, and we have passed House Bill 436 for you.
Thank you so much, ladies and gentlemen.
So let's see what we got. Okay. Okay, House Bill 183. Okay, Representative Knight, I'm going to pick on everybody today. We're not accountants, so we need a short, sweet explanation of this.
Madam Chair.
I know. It's so much fun to see you turn red.
I know. Madam Chair, one of your members is actually an expert in this, and just in case there's a very technical question, I'd love for him, as he's already here, to be up here. But a little brief history, Madam Chair and members of the committee. If you recall, many of you will recall from the committee last year, we brought this bill last session. We had several lengthy hearings on this. In fact, at the end of the session, we finally got folks from the Department of Community Health to actually admit, though it was very hard for them, that there was a loophole or an exception that is in the code. And from there, I'm going to start up again to make sure we understand the history. Basically, this is dealing with our private home care provider license. And if many will look back, it was in 1993, the licensure was created as we were looking towards the future with an aging, elderly, demographic coming. And unfortunately, there were some unscrupulous folks out there who were doing this. And unfortunately, in the original law, there was what I would call an exception or a loophole that was put in, and it was not clear on how some of these services would be provided. And it's why we're here today with this exception. What this bill seeks to do is make sure that we're strengthening the private home care provider license, to make sure that we're protecting those very people who are having having these providers come into their homes, okay, and help either sit with them or be with them or care for them. And what this does is eliminates the option that an agency can just rather go out and employ a non-skilled, off-the-cuff person to go into someone else's home. And that's what we're seeing out there today. With this important change, workers are provided, workers who provide this personal care companion or sitter task must be supervised by the agency professional, which is a registered nurse. In other words, a registered nurse is supervising, making sure that the care plan that is going on inside these homes is adhered to, and you actually have someone who knows what they're supposed to do as they come in and care for these folks. It continues to allow healthcare professionals to operate as independent contractors as long as they remain currently licensed in profession. In other words, if you got a nurse or a doctor, I'm not worried about that. Those folks are licensed elsewhere. They have the background and training. But we're talking about companions and sitters. And so with this legislation, the licensed private home care provider must employ, train, direct, schedule, and supervise its non-skilled workers to make sure that these services are properly delivered to the folks that they're going out and going into these homes. And quite frankly, as many of you know, the directives are already in regulation. That's the problem, is that the regulations are out there very detailed about the supervisory, the plans, all of the things that must happen. And we've got this loophole in code. Okay? So let's make sure that we do this real quick. You got okay. Again, the original legislation was to make sure that we protected an aging population. That was back in 1993, so we've seen our demographics change. This bill is going to make sure that we remove that exception or loophole such that these non-skilled workers are actually supervised, their employees are supervised and they're overlooked, and somebody's having responsibility for them. Yeah.
Let me just, Madam Chair, if I might just briefly emphasize a couple of points that the chairman has mentioned, and it's for everybody here that doesn't know. I've been providing private home care services for over 25 years. I've been doing this service when it was licensed, and I do want to emphasize that this bill back 22 years ago that we helped to pass was all about quality of care, and this correction today is all about quality of care. What we saw at the time was operators who were sending caregivers into homes that were unsupervised. In our business, what we do every day is deal with the most vulnerable in our society. The frailest of the frail, the weakest of the weak, the developmentally disabled. And you have to know that when you're sending caregivers into those homes, that they're supervised. And so what we've got, this loophole, just to emphasize what the chairman has said, really just allows people to consider their what should be employees as independent contractors. They aren't supervised. They just send people into the home, and it absolutely affects quality of care. And that is what this bill is all about. It only pertains, and I need to emphasize this, it only pertains to private home care providers and to no other industry, and I think that is about the gist of this. That is very simply what this does. Thank you.
All right. Questions from committee for Chairman Knight or our member, Mr. Representative Petrie? Okay. Representative Henson.
Thank you. I guess I have a few questions about this. You talk about supervise, and you talk about the registered nurse. Does that mean the registered nurse or someone with that training must be on the premise?
Representative Henson, the training by the registered nurse doesn't have to be done on the premises of the individual we're served. Is that your question?
No, the question is, does the registered nurse have to be a person that's on the premise?
On the premise that
All the
of the
time.
person. You know, you keep, I guess where I'm having some problems is you're talking about elderly and
Representative Henson, let me explain kind of the service. What we do is we send caregivers into individual homes, and so that the rules and regs that govern this industry require an RN supervise every caregiver. That training is typically done in an office setting, and then that caregiver is going out into the field into individuals' homes. Now, that nurse also goes into those homes, but they are not doing the training in the home. But what they're doing in the home is doing the supervision you're speaking to. It's our job to supervise to see that those individuals in the community are getting quality of care.
I guess my question is, if someone's there 12 hours a night, like I have a friend who has cancer, she has someone who comes in just to make sure that, you know, if she gets up in the middle of the night or something and is just dizzy, or make sure she takes her medicine, that and so forth. The caregiver can go in, but it doesn't have to be a registered nurse.
Absolutely. Most of our business is caregivers, and that is the beauty of this.
So Representative Henson, I think what it would be is the registered nurse would do training off the location, and then they would be making spot visits, unannounced. They might go to this house, not every day, not once a week necessarily, but show up to make sure their caretaker was there, that the patient that they were helping or the person they were helping was happy with them, they were meeting their expectations and doing what they were supposed to.
That is correct, Madam Chair. And I'll emphasize one other thing to Representative Henson. This only applies when you use a licensed agency. Again, this has nothing to do with people who hire their own individuals to work for them in the community as caregivers. This only relates to those that are licensed as private home care providers. Thank you.
Representative Jaspers.
Wait, that answered your last answer exactly. Thank you.
Okay, Representative Parsons.
Thank you, Madam Chair. I just wanted to ask, when you preclude the contractors from doing this work, and these people have to be employees, I'm just wondering if that, and you tell me what you think, but does that possibly create a situation where somebody might go without care because a particular company or organization like yours, somebody has quit, left, you have a shortage, and leaves you without being able to contract somebody who could be perfectly qualified to do that? I'm just wondering, does that?
That's a very good question, Representative Parsons. Here's what I would say. The overwhelming majority of providers in this state, overwhelmingly, do not use, because they believe, quite frankly, it is illegal to do so. I won't get into that. But they do not use independent contractors. So the overwhelming majority, and that's why many of them are here today, the groups that represent the providers are in support of this. So if somebody today is an independent contractor working for someone, all this will require is that the organization they're working for will do the right thing and treat them as a W-2 employee, because they're an unskilled, unlicensed caregiver, and they will continue to be able to work. And obviously it works because there's a thriving industry statewide of organizations that do this, but they need to do it the right way. So nobody, a great question, Representative, but no one would go without care.
All right, thank you.
Yes, sir. Thank you.
Representative Hatchett.
So I may be asking kind of the same thing here, but if I wanted to hire just basically like somebody that was untrained sitter, this is nothing to prevent me from doing that.
This only deals with license. If you go and you want to go through a licensed home care provider, that's it. You can go and get whoever you want to sit with, your mom, dad, aunt, uncle, whoever.
Chairman Knight, is it not true that we are having an epidemic across the state of our elderly that are frail and that need somebody to help them in their home being taken advantage of, both financially, from the people that go into their homes, stealing from them, getting their checkbooks and so forth, and also abused and being denied food and all. If you, as a daughter or son, go to a licensed provider, you should be able to expect a certain level of care that you as the provider have done a background check, have taught them how to take care of people, and that you are going to check on them and to make sure they are, and that you carry responsibility for that.
Madam Chair, you've nailed it. That's exactly what it is, because the companion, as I understand it, I'm sure Representative can more in detail, but it may be such as helping someone go to the grocery store, helping them mail their bills, or going by the bank or whatever. So it's not only from a health care point of view of helping people in and out of the, maybe the bathroom, or getting out of bed, or fixing meals or whatever, but it's also those other aspects. So at some point, that is where this licensed home care provider business is responsible. So if something does go wrong in that home, that person who's getting the health care, or maybe the son or daughter that is doing it, can go after that licensed home care provider, because they're licensed, they're a business, and they are taking responsibility for what happens and for that employee. Versus, this is exactly why we're here, somebody going out, getting somebody off the street, saying you're an independent contractor, go to this home, that's it. Okay?
Representative Drenner.
Thank you, Madam Chair. And I agree with everything that you're saying. I just want to make sure that I understand that we're talking about a licensed agency is going to hire a registered nurse to do the supervision. But I don't see anywhere where it says what supervision actually means.
In the regs.
That's in the broader code.
So that's where it says pursuant to Title 43.
Yeah, here's what that basically means. A licensed professional person, like an RN, LPN, nurse, therapist. What this is speaking to, this bill, is that all of those individuals you could hire them as independent contractors, but you cannot take unskilled caregivers and consider them independent contractors. But in every instance, according to the rules and regs for private home care providers, because your question is kind of beyond this bill, but that they are always supervised by an RN according to regulation. That is correct. They must be supervised by a registered nurse according to the rules and regs here in Georgia.
Representative Jenner, you know how in the last couple of years we have passed 2 bills making it, we have these little tiny personal care homes that are popping up with 2 or 3 people and they're ripping off their checks and we have made it a misdemeanor and this kind of thing, they're not licensed by the state of Georgia. These personal care home providers are licensed by the state of Georgia. There are rules and regulations, strict ones, that they go by. And that is where you will find the regulation that they have to have the registered nurse. That person is responsible for training and oversight. It's in those regs.
I'm just reading the sheet that
Okay.
they handed out.
Didn't do a good job.
And it caused more questions than just looking at the bill, quite frankly.
I'm sorry about that.
Betsy, where are those rules and regs? What part of the law are they in? I mean, that references back to them.
About the healthcare specialist?
The
Private home care providers.
providers and
It's chapter
their
111.
regulations.
Madam Chair, the rules, actually, the copy here, the rules are up under the Department of Community Health, chapter 111-8.
Dash 85.
85, yeah. 111-8-65.
Okay.
Representative Jenner.
Okay. So that's where they are in the law, Representative Drenner.
Okay, thank you.
But if there's any more questions, I'm glad to
Okay.
answer about that, if there's any confusion.
Yeah, all right, 31-7-308 is where that is referenced in the code to the regs.
Okay.
Okay. That's all. Any other further questions from the committee? Okay. Stephen Neff, if you would like to speak to the... Did you sign up?
Yes, ma'am.
You want to speak to it? Tell us who you are, who you represent.
Good afternoon, members of the committee. My name is Stephen Neff. I'm the Executive Director of the Georgia Association of Community Care Providers, which is the association, provider association, trade association that represents, along with another group, the majority of all of them in the state. We support the bill. It's a good piece of legislation. I'm happy to answer any questions. We believe it does exactly what the intent of it is to do, and that's to provide quality, safe care by good, trained caregivers in the state of Georgia.
Is there anyone else that wishes to speak to the bill?
Yes.
Okay.
Thank you, Madam Chair. I didn't sign up. I was in a Senate subcommittee. This is a bill that I discussed quite a bit with Mr. Knight last year, and it is a thorny problem. I'm Tom Balworth, Leading Age Georgia. I'm sorry. And I think you have committee sub in front of you. Is that right? I think that's a very good, workable solution, and we would support that. I think that's a good compromise.
Okay, thank you very much. Is that it? Okay. Representative Stevens, you're recognized for a motion at this time. Okay, I've got a motion to pass. Do I hear a second? I hear a second. Is there any further discussion from members of the committee? Okay, hearing none. Everyone in favor of the substitute to House Bill 183, say aye. Aye. Anyone opposed, say no. The ayes have it. The bill passes.
Thank you, Madam Chair, and,
You're welcome.
and members of the committee.
Thank you, Chairman.
Thank you.
Good job. That's for Ashley.
Okay. Well, let's see. We're moving along. Let's see if we can keep this moving. Okay, if I can get the committee back together, we are moving along, and Representative Parrish has asked that I present House Resolution 302 for you. As I think you've probably heard over the past summer, last year, Georgia has a critical physician shortage. It is to grow worse, and by 2020 we are expected to be 50th in the states in the number of physicians for every 100,000 citizens of Georgia. Can we call it together if you got it? Has everybody got it? We're working on a House Resolution LC 335780. And doctors tend to stay not where they go to medical school, but where they do their residencies. Over 50% stay where they do their residency. So the more residencies we can have, the more likely we are to get a few more physicians. High hospitals that already have residency programs cannot add to them. This was a rule made by the feds back in, I think, around 90, because they thought there was going to be a surplus of physicians. So we are encouraging hospitals across our state that are large enough and have the means to start residency programs to do so. WellStar is in the process and is going through the accrediting process and moving toward that goal. But training residents is a very expensive process. They tell me it's about $140,000. And the federal government, up until they put the freeze on, would pay about $80,000 of that. But if with this freeze and not having any more Medicare paid slots, then any residency program started here in the state of Georgia have to be funded by the hospital. Well, back last year, they made an exception and opened up that rule a little bit, and Georgia lost out. Florida got 200 new residency slots that are being partially and to a great deal funded by the federal government. We didn't get any. So this is an urging resolution for Congress to look at this situation again, and for our congressmen and our delegation and the governor and all to push for them to open this up again, and for Georgia to be approved for some federally funded residency slots. And I'll be glad to answer questions. Representative Hatchett.
At the appropriate time.
Are there? Who's 14? Representative Henson.
Madam Chair, how did Georgia lose out?
Ooh, I don't have any idea, Representative. I'm a state representative, not a federal one.
Well,
thank goodness.
I understand. Did we not submit?
I don't have any idea, Representative Henson.
Okay,
really.
thank you.
Madam Chair, I do know that I think we were 14th on the list, and the top 12 received slots. I think
Oh, good. Thank you. I hadn't heard that number.
We did submit.
Okay,
It could have
we
been
did
12 and 10, or I don't know which.
Did you hear it, Representative Henson? And he just thank you for that information. Other questions? Okay.
You know, the study committee we had this summer, we can start new slots in hospitals, but just the startup cost is between $3 and $5 million before we fund for the student and for the professor. So it's a very expensive process, and that's the reason that we were trying to move federally also to get some help with our own tax dollars coming back to Georgia through the Medicare funding.
Thank you for that information. So, all right, I'm ready to entertain a motion. Representative Hatchett.
Madam Chair, I move that we do pass House Resolution 302 LC 335780.
Thank you. I have a do pass. Do I hear a second? Got a second. Any further discussion? No? Okay. Everybody in favor say aye. Aye. Anyone opposed, no? No, the ayes have it, and I will tell Representative Parrish that it will be moving on. And if any of you talk to any of our congressmen, I would encourage you to ask them to move to it being opened up again and to talk about what a shortage we have in Georgia and that we can use any help that they can give us. So thank you very much. Pardon? Oh, is that? So are you volunteering? Okay. All right. We'll move to my bill. It's House Bill 394. Let me find my notes. Okay, I got them. All right, this is a cleanup bill. You may remember, for the people who were on the committee and here last year, and for the new people, a little refresher, we had two nursing boards. There was a nursing board for LPNs. It was a separate board. It handled and licensed and took care of LPNs. That's our licensed practical nurses, have usually 1 year of nursing experience. And there was another board that took care of licensing and the discipline and so forth for registered nurses. We joined the board together at the request of the Secretary of State's office, and this is a cleanup bill in a large degree from that, and also working with the Board of Nursing from some additions they wanted. One of the big omissions last time you find on line 60, the part that would allow them to discipline and enforce orders issued against LPNs was left out. So if there is a disciplinary action now, they really can't, those are issued as orders, and they really can't enforce the orders until we correct that. There was some antiquated language, like on line 263, about issuing temporary permits to work. We don't do that anymore in the state of Georgia. We had it, and there was another part that would have let people call them a graduate LPN and have a type license. It was in the RN laws. We had taken it away years ago, and this bill would remove that. So basically, this is a cleanup bill, and I will be glad to answer any questions that anyone might have about it. I can tell you that I am such a patient advocate that I guard very closely any changes made to the Board of Nursing or suggested by the Board of Nursing. If anybody remembers the Excelsior school fights that we had, their graduates who have no clinical experience don't come to Georgia anymore. And so I'm very protective of the people that are going to be, I'm very protective of patients and want only the best taking care of the patients in our Georgia hospitals. So I will be glad to answer any particular questions anybody has about this. One big thing that I disagreed with the board with and would not include, we have a requirement that they be able to speak and write English. And the board had suggested we drop that out, and I would not do that. I feel like patients ought to be able to understand the nurses, whether it's an LPN or RN that's taking care of them. So that's what I mean. I guard carefully how we treat the patients of Georgia. So I'll be glad to answer questions. And there are people here from the board, if they're more specific, that can answer them for you too. What's this? Representative Kelly.
Just a quick question. I was looking on line 358, 359. We're striking 5 years there from when they haven't been in practice, and they have to get additional requirement to a period of time established by the board. I was just curious what that time period is right now, or if the board has any idea what they may recommend that period to be.
Let's go. Can we have somebody from the board testify? Mr. Clayhart, can you?
Yes, ma'am. So it was an inconsistency excuse me, between the RN article and the LPN article. The RNs required 4 years, the LPNs required 5 years. The plan is to move it to 4 years, most likely, but to make it consistent between the two.
Okay, thank you.
No, is yours working? No, let's see. Representative Sharper.
Thank you, Chairman. Right here on line 263 through line 269, we see where they're striking where I know normally they would be able to work what they consider as a GPN. But I guess now, since they're striking this, would they just at this point just work maybe as a CNA or something?
That's right.
What they have license for, so it's not an issue?
Not an issue. They would,
okay,
until they cannot work as a graduate nurse.
Okay.
That used to happen for RNs too. We had a lot of RNs across the state that never passed their boards, or maybe they went 2 years to an RN school instead of 3 years, and they would let them work as graduate nurses. But we don't do that anymore. You have to finish school, you have to pass the exams, you have to meet the requirements to work as either a licensed practical nurse or a
okay, I guess I told my age on that too.
Pardon?
I said, I guess I told my age because that was a long time ago, over 20 years ago.
And you can remember a graduate?
Yeah.
Graduate like that.
Yeah.
So, here we go, who's number 12?
Long time ago.
Petra? Right, okay, Representative Petra.
Yeah, Madam Chair, I was just going to ask a quick question. On line 285 through 287, it mentions obviously being able to accept these nurses with an education program outside the U.S., and it says that determination will be made by the board. Just a question about the board's ability to analyze. Is that you fully capable of doing that from various countries? Y'all are able to handle that?
So the board relies on a credentials evaluation service. It's a national agency. It's titled CGFNS out of Philadelphia, Pennsylvania. It's the standard for nursing credential evaluation. They evaluate the education. They translate the transcripts for us. They look at the licensure of the country of origin. So yes, it's very thorough, and they tell us whether or not it's competent.
So it's thoroughly vetted, and it's something you can stand on?
Yes, sir.
Okay, thank you.
And it's the same way for the medical board. The medical board has an agency that's national that does that, so that when they look at a medical doctor coming in from another country, that they have a way of equating to make sure that their standards are equivalent to ours.
Thank you, Madam Chair.
Other questions from the committee? Is there anybody in the audience that would like to speak to the bill? No? Okay. So, therefore, any more questions from the committee? I'm ready. I will entertain a motion. I have a motion that we do pass from Representative Sharper. Do I hear a second? Okay, we have a motion and a second. Is there any further discussion? Okay. Everyone in favor of the passage of House Bill 394, say aye. Anyone opposed, say no. And the ayes have it. So we have the passage of that. Does that get it for the day? Yep. Okay, we are out in record time. Thank you for everyone that's coming. I really appreciate all the good attendance, and see you next time.